Great. Well, welcome everyone to this is our fourth regional anesthesia session that's supported by Chris Pabakar and Stephen Petrar from the St. Paul's site, as well as their fellow Aaron, who's presented for us. I am phoning into this Zoom meeting from the traditional territory of the Silks, the Sinaiaks, the Tanaha, and the Secwepemc. And of course, we're all phoning in from various regions across the province. So just want to recognize the unceded territories that we're all phoning in from this evening. Thank you to the FPAs for taking time out of your busy schedules. The evenings are tricky, and I know that there's family time and other activities that you could be doing. So really appreciate your dedication to supporting quality care for rural patients. And also thank you so much, Chris and Aaron and Steve as well, for your ongoing support of the rural GPAs in helping us to provide quality regional anesthesia to our rural populations. This evening, Chris is going to walk us through some abdominal wall truncal blocks, and I've been looking forward to this one because certainly as an FPA, a big part of our practice is inguinal hernia repairs and umbilical hernia repairs. So this is something I think that I will have a chance to use frequently. And then lastly, before I hand it over, I just want everybody to consider taking advantage of the coaching option of this educational series. This was really all brought about when Steve Petrar started beaming into Revelstoke to help us do some blocks. And it's a super cool experience. I connected with Steve a couple of weeks ago, and through basically a remote presence device, basically a fancy iPad, Steve was able to beam into our operating room here in Revelstoke, and he provided some guidance and support for a sciatic popliteal block for a woman who was having a plantar fascial release, and it was fantastic. The video was great, and Steve it was like he was there in the room with me. So this option is available to all of us through our ARSON funding, and if you're interested, please reach out to Emily, who can make the connections. Most of us know Steve and Chris already, so I'm sure you guys wouldn't mind if some of the FPAs reached out to see whether that might work for a scheduled case. So please, guys, take advantage of that. It's a huge, it's a wonderful service, and I think you'll really enjoy it. So with that, I'll hand it over to Chris, and I look forward to hearing about some truncal blocks.
Okay, thanks, Kirk. I'm just going to get things set up here. Okay, so hopefully everyone can see my slides here. So I'll just go over the more formal part of the presentation, where we'll talk about 3 or 4 different types of abdominal wall truncal blocks that you can apply to your clinical practice. And then Steve and I and Aaron as well will be happy to have any questions that you might have about how to apply those. I should say I don't have any conflicts to declare. And I do want to acknowledge that I live, work, and play on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh people. So this is what we'll go over over the next 40 minutes or so. We will talk about fascial plane blocks in general. We'll go over the anatomy of the innervation of the abdominal wall. And then we'll talk about tap blocks, rectus sheath blocks, and blocks for inguinal hernia repair.
This process. Currently, it just takes too long. Through tax credits, stimulate automation.
I think there might be someone with their audio on. If you wouldn't mind muting, that would be great.
And ensure employment insurance doesn't keep workers from returning.
Move on here. Okay, so we'll just talk about the mechanism of action of fascial plane blocks. These are very different in many respects than the traditional nerve blocks, like the sciatic block that Kirk was talking about, where you see a distinct nerve and you put local around that nerve and it numbs the entire area, whether it's a limb or a part of the body. Instead, what we're doing is we're injecting usually more dilute and usually larger volumes of local anesthetic in between muscle planes. And it's not really clear what the mechanism of action of the pain relief or analgesia is. There are some purported mechanisms. There are nerves traveling within those planes, and that's what this picture shows. A number of different tiny branches of nerves that we can't see with ultrasound that travel between, here between the pecs and the serratus muscles. And so if we dump some local in that plane, then we should be able to numb some of those nerves. As well as there's a dispersion of the local anesthetic to adjacent compartments, and a classic purported mechanism of where that's seen is with the erector spinae plane block, where it's thought that some of the local translates into the paravertebral space and works that way. As well, perhaps anesthetizing the muscles directly causes muscle relaxation, so there isn't as much spasm, and maybe that's the mechanism for some of the analgesic benefit that we see, and perhaps to other connective tissue as well. And finally, there's very much likely a systemic component where absorption intravascularly has some degree of pain relief. In terms of advantages, there are a number, and we can see that in the amount of research and the amount of workshops that are being done at various anesthesia conferences about these fascial plane blocks. They are simple and relatively easy to do in comparison to standard ultrasound-guided nerve blocks or perhaps neuraxial techniques. Usually you're going at a much more superficial insertion angle with respect to your needle, so you can see it a little bit easier. There may be lower risk of injuring nerves because you're not targeting, you're not trying to get as close as possible to a nerve. You're not going into the epidural or intrathecal space. So there may be lower risk of needle trauma, lower risk of hematoma that could happen in that epidural space, and lower risk of direct local anesthetic toxicity to nerves. As well, perhaps the side effect profile may be better, particularly in comparison to neuraxial techniques like epidurals and spinals, where you may have, with fascial plane blocks, you may have less urinary retention, less pruritus, less mobility issues, with epidurals affecting lower extremity movement, and you'll have less of a sympathectomy, so less cause for hypotension. However, there may be some significant disadvantages. One of them being the variability in the response. And part of it is with the insertion technique. And I put this picture up to show you frame A, you've got a deposit of local anesthetic. This is a PEX block. And there's an attempt to deposit the local anesthetic between PEC major and PEC minor. But the initial injection there is really lifting PEC minor up. So you're not really in the proper fascial plane. And it's only when you go to frame B that you see that there's local really unzippering the plane between the muscles and not just lifting up that muscle. And of course, different fascial plane blocks will have different levels of ease of determining whether you're in the right compartment or not. But that's one of the things that I find kind of challenging with fascial plane blocks is once you get a little bit of local in the wrong area, sometimes it's hard to get it back into the right compartment. Most of the time we're doing these as single shots. So in comparison to an epidural, say, where we leave a catheter in, the duration may be limited to 10 hours or so at most, potentially. There are some catheters that are used for these fascial plane blocks, and it's, to be honest, not something that I've done terribly often, but on occasion have to variable effect. You do not get visceral analgesia because you're not injecting near the neuraxis. You're not getting the intra-abdominal organs anesthetized or analgesed as much as you would with an epidural. And the question of success, it's hard to determine. Whereas with a brachial plexus block, if you numb the nerves and you get a nice dead arm that isn't moving and where the patient can't feel anything, you know you've had a successful block. But with these fascial plane blocks, sometimes, you know, you may not get cutaneous paresthesias or hypoesthesia, but there still may be some analgesic benefit from the mechanisms that we've talked about earlier. And of course, by and large, most of the time, these do not provide a dense enough numbness level to provide surgical anesthesia. Thinking about variability of success, this was an early study from 2015 where volunteers had TAP blocks, and you can see they marked out the level of decreased sensation, that they can be very variable. We'll go over TAP blocks specifically and how we can try and improve upon that success. So going into the anatomy of the abdominal wall, if we start anteriorly, we see where you've got the rectus abdominis muscles, right lateral on either side of the linea alba of the midline. And then as we progress laterally, we have the three muscle layers, the external oblique, the internal oblique, and the transversus abdominis. So that's going from outside in. And then as we follow those muscle layers posteriorly, we come to the psoas muscle, the quadratus lumborum, and your erector spinae muscles. Now, when we think about the nerves traveling within those muscle layers, we've got spinal nerves. We've got spinal nerves that travel from the vertebral canal, and they travel between the internal oblique and transversus abdominis muscles until they reach the rectus abdominis, and then they pierce through rectus abdominis muscle to provide a medial branch going midline and a lateral branch going a bit more laterally towards the anterolateral abdominal wall. But we have to keep in mind that there's also a lateral cutaneous branch that cuts maybe around the mid-axillary line through internal and external oblique to onto the surface of external oblique, which has an anterior branch to innervate most of the anterior lateral abdominal wall, as well as a posterior branch. And if we look at this cut here, we've got on this side external and internal obliques cut away, and we have those anterior cutaneous branches of the spinal nerves lying on top of the transversus abdominis muscle going towards the midline. But over here on the, and I'll just put up that image that we had from before, over on this side where we have external oblique still on, you can see those lateral cutaneous branches corresponding with this branch that cuts through at the mid-axillary line and comes anteriorly. These are those branches that we see on top of external oblique, as well as the anterior cutaneous branches that cut through over here into through rectus abdominis, poking through the aponeurosis of external oblique. There we go. So that's just another reminder of how the abdominal wall works. Rectus abdominis anteriorly, the three abdominal wall muscles going out posteriorly to the end where we coalesce with quadratus lumborum. And here's the ultrasound image of that. We'll just get that going. Rectus abdominis, and now we see those three muscles here, external oblique. The thickest is usually internal oblique and transversus abdominis, and then abdominal contents deep to it. And here you can see the transversus abdominis muscle tapering to an end, and that's a key landmark that we'll come back to. So in terms of the TAP block, our anatomic targets are both those lateral and anterior branches of the spinal nerves from T10 to T12. So that will innervate really the lower abdominal wall in the anterolateral area. We're also targeting ilioinguinal and iliohypogastric nerves. Indications, probably the main one that I use is for C-sections where I've provided a general anesthetic, so I haven't given intrathecal or epidural morphine. And that's where there's significant benefit to doing these TAP blocks postoperatively. As well, there's RCT evidence for benefit in total hysterectomy and other gynecologic surgery, laparoscopic surgery, and colorectal surgery, particularly when there isn't an epidural in place. And as you can imagine, if you're targeting this lower abdominal area, any fan and steel incision or lower infraumbilical incision, it may be beneficial to doing a TAP block. In terms of the technique itself, you can see here we're positioning the patient in the supine position, and we have the ultrasound probe in a transverse orientation. The reason why I put this particular picture in is I want you to be aware of how posterior that probe is, because we really want to be targeting the end of that transversus abdominis muscle. There are lots of pictures of people doing their tap block anteriorly or in the mid-axillary line, but I'd encourage you to start targeting more posteriorly. And if you need to, you can always put a bump under the hip to be able to access that area. So we want to target the plane between internal oblique and transversus abdominis, and we want the local to get to that posterior end of transversus abdominis. The typical volume is 20 to 30 mLs per side, 0.5 to 0.25% ropivacaine. The volume is a bit variable. What I usually do is I want to at least give 20 mLs of local, and I'll base that on the patient's weight. As we talked about, as Steve talked about in an earlier session, we do want to be aware of the risk of local anesthetic toxicity, particularly with this type of block. And then I'll target the concentration. So if the patient has a large enough body weight to have 20 mLs of 0.5% ropivacaine, then I'll do that. But if they have a lower body weight, I'll dilute it down to maybe 0.25% ropivacaine. This small pilot study showed that if you can maintain the concentration, 20 mLs of local anesthetic will potentially maintain analgesic effects up to 48 hours after the block insertion. You do get some dermatomal loss, particularly as you dilute the local. So the green is with 0.33% ropivacaine and the yellow is with 0.25% ropivacaine. So this is a video of the block technique taken from Jeff Gadsden and the Duke Regional Anesthesia Group's YouTube video, which is a phenomenal series. I'd encourage all of you to take a look at it. See if I can get the video going. There we go. So here we are. These are the tap plane. There's the internal oblique. It's definitely thicker than the rest, and peritoneum below. And we're just scanning to get to that edge of the posterior edge of transversus abdominis. And now with the needle insertion coming in at a relatively flat angle so that you can get all the way over there. You want to just pop through the internal oblique muscle, and you can see that unzippering, as Jeff likes to call it, with the local anesthetic, opening up that plane. And then what this video shows is the movement of the needle and using the hydrostatic pressure of the local anesthetic to continue to open up that window posteriorly to get all the way to the posterior edge and end of transversus abdominis. And there you go. There's the end of transversus abdominis, and you're pushing the local well past there. Okay, so we'll move on to rectus sheath block. So this is a block that is advocated actually by the Regional Anesthesia UK group, where they have 7 blocks that they think that every anesthetist should know, and this is one of them. So we'll just briefly talk about the anatomy of the rectus sheath itself. So the rectus sheath, we're looking anteriorly here at the rectus abdominis muscles, and the sheath is comprised of the aponeuroses of those lateral abdominal wall muscles, so external oblique, internal oblique, and transversus abdominis. And we have to be aware of what happens above the arcuate line and below the arcuate line. Just as a reminder, the arcuate line happens to occur somewhere between the umbilicus and the symphysis pubis, usually about a third to half of the way down from there. So above that line, the aponeuroses of external oblique and internal oblique goes anterior to the rectus abdominis muscle to form the anterior rectus sheath, whereas the aponeurosis of the internal oblique also splits posteriorly, and it, along with the transversus abdominis aponeurosis, form the posterior rectus sheath. Below the arcuate line, all of the muscles go anterior, the aponeuroses go anterior, so there isn't a posterior rectus sheath muscle. And so it's thought that below the arcuate line, you may not want to do a rectus sheath plane block because you're at risk of cutting through the transversalis fascia and the peritoneum and causing a peritoneal injury. On ultrasound, above the arcuate line, I hope you can appreciate, I don't know if this is big enough, but that there are these double white lines in that posterior rectus abdominis area here. Whereas below the arcuate line, it's just a single line, and that's the muscle sitting directly on the transversalis fascia and peritoneum. Now, the goal of the local anesthetic in our needle is not to go between these tram marks, but actually to lift the muscle off of that superficial tram mark, which is the posterior rectus sheath. And just as a reminder again, here's that spinal nerve cutting through rectus abdominis up here, and it tends to pierce that posterior edge of rectus abdominis approximately 1.5 to 2.5 centimeters medial to the lateral edge of rectus. So you want to stay on the lateral side of the rectus muscle, and then it forms those medial and lateral branches. Now here's just a clip of rectus, and you can see abdominal contents just deep to the double tram marks of that posterior rectus sheath, and then the peritoneum and transversalis fascia. We're targeting the anterior branches of the spinal nerves between T6 and T11. Main indication based on RCTs is umbilical hernia, but any midline incision, particularly for us, if we have an emergency laparotomy, this may be a nice rescue block of a patient having significant pain postoperatively. And what you want to do is basically target the area where the significant amount of pain is. So if it's a periumbilical incision, then you can target just around the umbilicus and get 1 to 2 levels spread up and down from where you're injecting. If the incisional pain is more higher up, closer to the xiphisternum, then you can inject just at that point. In terms of the technique, again, the patient is supine. Most commonly, I've seen and done a transverse orientation. Some people suggest a sagittal one, but I've never actually attempted that myself. As I mentioned before, you want to target the posterior rectus muscle and lift the muscle off of the posterior sheath around the lateral third of the rectus muscle. And the volume here is about 15 to 20 mLs per side. And again, the rectus sheath block, just like the TAP block, because you're injecting potentially close to muscle, which is highly vascular, there is a risk of local anesthetic toxicity. So you want to be aware of your doses, and you want to monitor patients after you've done these blocks for approximately 30 to 45 minutes afterwards. It's been found, particularly for the TAP block, that your absorption and peak plasma volumes may occur at 30 to 45 minutes. Another option is adding epinephrine to the mix to decrease absorption. So again, this is Jeff Gadsden's video on rectus sheath block. You can see his needle cutting through rectus abdominis, getting to that posterior sheath, and then injecting to lift up the muscle. And you may want to, in this particular block, stay on the superficial aspect. So start with an intramuscular injection of rectus and then slowly advance until you see that nice black lens-like lenticular local anesthetic deposition there, as opposed to going too deep and accidentally going through the rectus sheath. Now, one thing to be aware, I mean, in general, for any block that you do, it may be prudent to put color Doppler on to scan the needle trajectory to make sure there isn't a vessel in the way. But for rectus sheath blocks, you definitely want to do that. There are your superior and inferior epigastric artery branches that are traversing through there. And oftentimes they are on that posterior edge, sort of sitting initially on the posterior rectus sheath, and then they cut through rectus abdominis muscle. And so you can see here, we found some arteries here that we want to definitely avoid. And there have been definitely case reports of significant hematomas after this block has been performed. So something to keep in mind. Okay, we'll move on to blocks for hernia repair. So the classic one that is often taught are the ilioinguinal and iliohypogastric nerve blocks. So these are nerves that are traditionally thought to come off the lumbar plexus, so L1, although anatomic studies suggest that both of them may have contributions from T11 to T12 as well. Now, what's different about these two nerves as opposed to the spinal nerves that we talked about earlier is that as opposed to, you can see up here, they are lying on top of transverse abdominis, but as opposed to the other nerves that were coming in that plane all the way to rectus abdominis, these two nerves tend to cut through internal oblique and external oblique a bit more laterally as they go down to the medial portion of the abdominal wall. And you can see here, the iliohypogastric nerve tends to anesthetize the lower abdominal wall, the ilioinguinal even lower down into the perigenital area. But we don't cover everything. You can see that there are a number of other nerves, including the genitofemoral nerve that goes into the pubic area and the medial, and also innervates the medial thigh there, that not all components of a block for hernia repair are done with just these two. So it's just important to keep that in mind. Our anatomic targets for conducting this block are just like the tap plane. We want to, just like the tap block, we want to be looking in between transversus abdominis and internal oblique. Oh, I have a little typo here. Indication. So inguinal hernia is the main one for which this is done, but any surgery involving the medial or upper thigh potentially, or the lower abdominal wall. Some people, so there have been some studies for bend and steel incisions, but for that, it's probably thought that tap block is preferred. So in terms of technique, again, patient is supine. The ultrasound is in a transverse orientation, just medial to the ASIS. Sometimes you might have a bit of oblique orientation from the ASIS pointing up towards the umbilicus. The target, again, is that plane between internal oblique and transversus abdominis. And sometimes when we're right by the ASIS, the abdominal abdominal muscles are a little bit more distorted than the traditional look that they have in the ultrasound images we've seen prior. But what we can use is this DCIA, which is the deep circumflex iliac artery. So a branch of that artery oftentimes is in that plane with the two nerves and can help us to delineate that plane as well as where the nerves may lie. You can use a smaller volume of local if you can find those nerves. 10 to 15 mLs is what I typically use. And the other concern that has happened with this type of block and has been described is a femoral nerve block that you can get. Not the ideal thing you want when all you were hoping for was some analgesia for hernia repair. So I think it's important to monitor post-block and probably post-operatively for any femoral nerve blockade that may mean that the patient needs to be admitted until that block wears off. So you can see with this image, we've got ASIS up here, and that's the black shadow that we have in this corner here. We have our muscles, external oblique, internal oblique, and transversus abdominis. And then our red arrows are pointing to the iliohypogastric nerve, ilioinguinal nerve, and there's that pulsating structure, the DCIA, deep circumflex iliac artery. And then deeper in, you may have peritoneum. So that's important to remember. Now, this is another image. This is from the USRA website. Again, same thing, ASIS here, your three abdominal wall muscles. Oftentimes, internal oblique is the thickest still. And sometimes external oblique can be quite thin here, and you may not appreciate it. But what you want to do is you want to make sure that you're looking at the right muscle layer. And you can imagine that if you didn't think this was the right muscle layer, maybe you thought that this would be the tap plane. And I would caution you about going into this area because here, this is actually your iliacus muscle. And this structure over here looks a little bit hard to see, but I think that might very well be your femoral nerve. So in this case, I would caution people who are doing this block to conduct themselves in a few different manners. First, make sure that you are looking at the right plane. Sometimes what I do, if I'm not positive, is I will scan up above ASIS to where I see a more traditional TAP plane with the 3 layers, and then I'll scan down and follow that internal oblique muscle down. And we don't want to be aiming into this deep portion. In fact, I would suggest that we don't even aim to be deep into the transversus abdominis muscle, but if anything, I would aim to be in internal oblique and slowly make my way from internal oblique into the plane between internal and transversus abdominis. And then I also like to keep the local volume on the lower side so that none of it migrates through potentially a thin transversus abdominis muscle to anesthetize this femoral nerve. So here's a little video of internal oblique here and transversus. Here's our needle coming in just by this target here, which is the iliohypogastric and ilioinguinal nerves, along with the DCIA. So that's our needle coming in. And then the local, you can see we're probably a little bit superficial. We're infiltrating into internal oblique, which is okay. So the needle goes in a little bit deeper. And now we're lifting the IO muscle off of those nerves. You can see after we've had a deposit of 10 mils of local, you can see 1, 2, 3 structures, which are likely the 2 nerves and the 1 artery that we've talked about. The last thing I'll talk about is something that isn't really described in the literature at all, but it's something that we've been doing at St. Paul's for the last couple of years, I think. And what I can say is that I used to just do the ilioinguinal iliohypogastric nerve block, and I would find that the patients were oftentimes not having complete surgical anesthesia at the area of the incision. Now, I know that some surgeons do these inguinal hernia repairs under local infiltration alone, and they can do it well. At Mount St. Joseph's Hospital, we have Victor Sang, who does a very nice technique on all of his patients. They have minimal pain, and he takes his time, deposits the local, is patient with allowing the local to work, and just dissects a little bit at a time. There's another surgeon at an ambulatory surgical center, Mark Volosha, has a similar, slightly different technique, but again, that works well. But there are a number of surgeons that we have that cannot do this technique well. They're either impatient with allowing the local to work or aren't injecting into the right places. And so what we've started doing is we've taken that over. We've started injecting the local prior to going to the operating room. And so for surgeons that can't do this surgery under local infiltration, we can help with that. And it's a nice technique to know, particularly for patients who are too sick, who we think are too sick, or who may have complications after a general anesthetic. You know, your elderly patients or patients with cardiopulmonary disease, we want to avoid giving a general or intubating if we can. There we go. Oops. All right, I've gone ahead here. Let me just go back. There we go. So some of the advantages of us injecting before the surgeon has even prepped the patient, I guess the nurses have even prepped the patient or the surgeon has even scrubbed, are that it gives the local anesthetic some time to work and to provide a nice dense block. It may give the local time to diffuse away. And one surgeon has told me that she prefers us doing it because when she injects local, it obliterates or changes the anatomy, and it also doesn't allow cautery to work as effectively. But when we inject, there's 20 minutes between injection and surgery, so it allows the local anesthetic to diffuse away and allows the cautery to work well. And I believe that we inject a little bit slower and a little bit more with a bit more of a mindful approach, and so it's less painful for the patients as well. They're less anxious in the block room usually than when they're in the operating room. So I think for those reasons, there are some significant advantages to us doing it. So I'll just go over what we do. So first, again, the patient is in a supine position. I do like to get the surgeon to mark the incision before I start, because I find every surgeon has a slightly different approach. Some people will have a straight transverse orientation to their incision, regardless of what the hernia feels like. Others have what we have here, an oblique incision. So I just like to know beforehand. And what we're going to do, and what we do is put our local and put our ultrasound probe on top of that incision and just inject in an in-plane technique in a few different fascial planes. So the first thing that we do is we'll inject some local just with a regular 25 gauge needle and raise a wheel along the length of the incision, even before we use the ultrasound. The next step that I routinely do is I scan for the femoral nerve, and then I translate my ultrasound probe to where the incision marking is. And as you can see here, usually, by and large, the femoral nerve is deeper and more lateral than where the incision for the inguinal hernia is going to be. I just like to make sure that I'm well away from the femoral nerve before I start sticking my needle in too deep. So here you can see femoral artery, and just under fascia iliaca here is this indistinct structure that is likely the femoral nerve there. So I'll go from there over to where the incision is, and that's what this is an ultrasound image of. So we're scanning medially, and now we're overlying the incision. You can see here we've got some bowel contents here, and this may be the hernia right in this area. So I do like to look for peritoneal movement and make sure that I stay superficial to that. And as you can see here, we've got maybe 1 or 2 fascial planes. So what we'll be doing is we'll be opening up those layers. So we're going to be then using our block needle, which is a bit of a longer needle, a bit duller and more echogenic, to be able to open up those fascial planes. And I want to make sure that I get from one side of the incision, from the lateral side, all the way to the medial side, just to make sure that I cover the area underneath the incision. You can see the needle coming into this fascial plane here, and then just opening up a plane within the tissue, going from the lateral side over to the medial side. Here's another clip. Now that we've got a bit more local in, you can see we're opening up a different plane. This is a deeper plane to anesthetize the area under the incision. So this isn't completely local free by the surgeons. They still have to inject because oftentimes the peritoneal sac or the spermatic cord, because those are innervated by other structures, in particular the genitofemoral nerve, which is a bit deeper and one that I don't tend to do routinely myself. The surgeon will need to inject in those specific areas. So you do need to save some room for local for the surgeon. And then, as I've mentioned a couple of times now, I like to do a femoral nerve assessment post-operatively. And we've had a couple of cases where we've done a block and the patient has developed a femoral nerve weakness post-operatively. We've had it where we haven't done a block, but the surgeon has done local infiltration and the same thing has happened. So I think in general, if one is doing inguinal hernia repairs where local anesthetic is being injected, it's prudent to assess for that prior to mobilizing the patients. I typically use about 20 mLs in this local infiltration technique. I use a mix of lidocaine and ropivacaine, but one could potentially just use straight ropivacaine for a more prolonged analgesia. So that's it in terms of the talk, at least the formal portion of it. We've gone over some of the benefits of fascial plane blocks, the anatomy of the abdominal wall and where the nerves are traveling, and talked about 3 or 4 different techniques for abdominal wall surgery. Happy to take any questions, and thank you for showing up and for your time. And feel free to email me if you have any questions at all. Be happy to answer them at a later time too.
Great, Chris. Thanks so much. That was super interesting. I look forward to trying some of those tricks in the days ahead. Do you guys just want to jump in with your questions? I think that that will be that will be fine. Or there's a few people posting in the chat too. So either way, please feel free to ask some questions.
Okay, I see Devin. Hey, Devin, how you doing? It's good to see you. He has a question about how many insertions are you doing along the incision for the local infiltration technique? Steve, I'd be interested in knowing Steve's technique. So I'd ask Steve for his, because I think he gets maybe a little bit closer to the hernia sac than I tend to. I tend to only have one insertion for the most part, but if I can't make it all the way to the medial edge of the incision, then I may insert a second time.
Thanks, Chris. Awesome review. That was outstanding. To your question, for me, for these cases, what I tend to do is I tend to do an ultrasound-guided ilioinguinal iliohypogastric block, just as you described, 10 to 15 mils under ultrasound there. And then what I'll do is I like to actually, whenever possible, identify the hernia sac under ultrasound. And sometimes it's obvious, and other times it's not as apparent if it's fully reduced, or if it's a very small hernia or an indirect hernia. But what it will, in essentially every patient, I will attempt to, identify it if possible. And sometimes that may require having the patient do a Valsalva maneuver or something while I'm ultrasounding, and that can accentuate the hernia, of course. And when I can see it, then what I'll typically do is I'll just put, as you described, 20 mils of local into several fascial planes, kind of just sort of above the dome of the hernia where I feel like the defect is. And so I'll try to just go, as superficial as possible, really just subcutaneous almost, just into whatever adipose there might be, put a little bit there, and then drop down a plane or two and do the same thing as you described, all under ultrasound guidance. And I'm always mindful of those arteries and vessels.
I'll tell you, since I started doing this local infiltration technique, I've really, it's gone from a block and a surgery that I really didn't like doing, because I would do this block and I felt a bit bad giving this patient over to the OR anesthesiologist, because they'd oftentimes have to sedate the patient fairly heavily, because there'd be a lot of poking and prodding and pulling and tugging that the patient would not like. And now with this added technique to the ilioinguinal iliohypogastric, it's very minimal, the amount of pain, and the surgeons are impressed oftentimes and are asking us to do this for their patients. So it's gone from a block that I didn't really like doing to a block that I really enjoy doing, because I can see the benefit to the patients.
Yeah, I'm the same way. I quite like doing it as well, and I think I'm looking for the hernia more just for fun, more than anything. I don't know whether that's necessary, but I've had good results. I've had good feedback from our surgeons. I do the blocks, and the patients seem to do pretty well. So yeah, for what it's worth, it seems to be working for me.
Guys, is there much advantage in doing the block for postoperative analgesia and a patient that's going to have either a general anesthetic or a spinal anesthetic for their primary mode of anesthesia for the case? Especially the spinal. I tend to do them if it's a GA, but then I don't tend to do them if the patient's going to have a spinal, because usually they leave feeling fine if they've had a spinal anyway. But I find I get a lot more benefit in the recovery room if they've had a block in and they've had a GA.
I think there is benefit. There are at least a couple of RCTs that have shown that both TAP blocks as well as ilioinguinal iliohypogastric blocks are beneficial in terms of chronic pain. And so that's where I think there may be some benefit. I mean, they're small trials, so maybe it's hard to know if that's a real effect or not. Sometimes we see these positive results in smaller trials that get negated in larger trials. But because there aren't those larger trials at this moment to negate them, I think that it may be beneficial to do them, even if the patient's going for a GA or even a spinal potentially. Yeah.
Chris, could I ask you a question, just as a colleague? If you wanted to make a comment, it wasn't mentioned in your presentation, but just if you had any comments on patient selection for this technique, and if that influences your practice as well. Is there certain type of patients that tend to do better and others that you might avoid for this?
Oh yeah, that's a great reminder. I thought I put a slide in that you really need 3 motivated people. You need a motivated patient for sure. So they have to be okay with this. You don't want to be coercing or persuading anyone to a technique that they aren't comfortable with. And that's the same thing goes for the surgeon. I've had surgeons that are, by and large, happy with the technique, but other surgeons may not be, or may be doing it reluctantly. And then it probably doesn't work as well because they may not want to or be as, I guess, have the buy-in of doing a proper local anesthetic that they do need to do. And as well, you have to have a motivated and onboard OR anesthesiologist. Now, we're lucky in that we have OR colleagues that we oftentimes transfer these patients to. For some of you, it might be that you're doing the blocks and then providing the anesthesia afterwards. In terms of the actual patients, I think body habitus can be a big challenge. So larger body habitus patients may not tolerate this as well because you have a lot more tissue to get down to. And we may not be able to anesthetize all of that percutaneously with our technique. As well, larger hernias or incarcerated hernias, there may be more pressure that needs to be used to reduce them. And so I usually talk with the surgeons beforehand about those parameters and whether there are any that might contraindicate the patient from having it done under this technique. I don't know if you have anything else to add, Steve.
No, I think that covers it. The only other one, but maybe this is just purely bias and not substantiated in your experience, but age can sometimes be a factor. I find have a very young man or whatever, and they may not be as great a candidate for this, but some of our older patients seem to do better.
Yeah, I would agree. It's amazing sometimes these older patients do phenomenally well without needing any local supplementation.
Which is great because that's, that's really the demographic that you're wanting to capture here. I think for me, if it's a younger ASA1 patient or something, I'm maybe more comfortable doing doing general anesthetic for that person. Whereas if it's an older, frailer ASA 3 or 4 patient, then I think what you've described would be my preferred option.
Mm-hmm. There's a question, is there any post-op analgesic advantage as supplementation for endoscopic hernia repair? I'm not sure, is it laparoscopic? Maybe that's meant. That's a good question, yeah, okay. I should look that up as to whether there is a benefit. I was focusing on open repairs, but I don't know for sure that there is a benefit to laparoscopic. It may be, there's definite, as I mentioned on one of the slides, for TAP blocks, there is RCT evidence that for any laparoscopic surgery, there's analgesic benefit for TAP blocks. And it may be that what we're doing is we're anesthetizing those muscles so that when they're stretched from the laparoscopy, it's not causing as much discomfort. So TAP blocks may be beneficial because they have maybe broader analgesia to the abdominal wall as opposed to ilioinguinal, iliohypogastric blocks.
And for Dr. Mundy there, I would say our practice at St. Paul's is that if it is expected to be a laparoscopic hernia repair, we wouldn't typically offer that person either of these blocks. Perhaps we should. We will look into that evidence, but at the present time, it's not our usual routine.
I had an interesting experience with one of those a couple of weeks ago. We had a surgeon do a laparoscopic bilateral inguinal hernia repair with mesh, and I don't know if it was good or bad, but I think my block rate was 50% because you could sure tell the side where I got my local in the right place, and you could sure tell the side where the local wasn't in the right place because the patient had absolutely no pain on one side, and on the other side, poor guy was in agony.
Oh,
so it kind of opens yourself up to identifying when you're when you're batting 50%.
I oftentimes have a competition with the trainee, whether it's a resident or fellow, where I'll do one side and they'll do the other, and we'll see how the patient does afterwards. But I'll be honest, even like I don't do a lot of these fascial plane blocks, thinking mainly about TAP blocks, but it's variable how successful I am. I find that it's a challenging block to do. It looks great on some of these videos, but the reality of some of our patients makes it a bit more challenging, and knowing where precisely you are. So there's a question from a comment from Dr. Pearson. Are rural hospitals without block rooms? If the patient is having a GA, often the surgeon expects the TAP or rectus sheath blocks to be done at the end. Okay. And I sometimes find air artifact messes with me trying to do it after. Yeah. Would you encourage us to do it prior to surgery? If timing allows, there may be a benefit to doing them preoperatively, to be honest, because as I mentioned, it may anesthetize those muscles. So the stretch that if it is laparoscopic, but even the tugging and whatnot that is done intraoperatively, hopefully some of that will be covered by the block. And so you'll need to give less analgesic and less opioids. And so I think if timing allows, it may be beneficial to doing them preoperatively. And usually these are short enough surgeries where you're not worried about the duration. If it's a 4 or 5 hour surgery, I sometimes think, oh, it's probably better to do it at the tail end. And oftentimes for the C-sections, I do them at the end because usually it's an emergency for why we're doing the C-section under general. But for elective surgery, there may be an intraoperative benefit. as well as the fact that what you say about the error artifact. I've definitely scanned post-laparoscopy patients, and yes, it completely sometimes obliterates everything, and you can't see at all the planes that you want to get to.
Great. Thanks so much, Chris. And thanks, Steve, as well. Just one last opportunity for those of you that maybe tuned in a little later on. These sessions also come with a possibility for virtual coaching at your hospitals too. And I've had wonderful experiences with having Steve beam into our hospital in Revelstoke here with the virtual technology, and it's been really great. So Steve and Chris are both quite keen, and Aaron as well have volunteered or have offered to provide that service to us. So those of you that have RSWAN funding, you can use that to do coaching sessions with Steve or Chris. So if you're interested in doing that, I'd highly recommend it. It was a great experience for us here in Revelstoke, and I think it's improved our blocks tremendously. So consider that, and if that's an interest to you, you can reach out to Emily or Chris and Steve directly. If you have any questions about the technology side, we've got Tom Skinner here as well, and he can certainly help out with that part. So with that, a final thank you to Chris for a fantastic presentation. It was very informative and entertaining. And I hope everybody else had as much fun as I did. And we look forward to getting some other sessions up and running, maybe in the winter or spring.
Thank you so much, Kirk. I just want to jump in before you sign off to answer Jane's question. She's asking how much notice would be required, and I'm assuming she means to set up a coaching session. I mean, it's not rigid. We're around. Our regional anesthesia group is relatively large, and I've sort of had off the cuff conversations with most of my colleagues, and they're generally all receptive to the idea and willing to participate. So, if it happened to be a day where Chris or myself or Aaron were not available, we can usually find somebody else. Certainly notice helps, but if it's less than 2 weeks, don't feel shy about reaching out. If it doesn't happen, it doesn't happen. But if possible, we can usually find somebody, I would say.
Great. Thanks, everyone.
Okay.
Fantastic. Thank you so much. And I'll follow up with a little bit of a follow-up email with some information about an evaluation and all of the recordings that we've done so far for our 4 sessions. Thank you so much, team.